Hi, everybody. Thanks for coming. Thanks for joining us, both in person and virtually. Today, we're going to talk about toward a brighter future for preventing COVID-19 in patients with hematological malignancies. And we're going to talk about using some current strategies and next-generation agents. Today's panelists are myself, my colleague, Dr. Haidar, and my colleague, Dr. Huff. Thank you to Penn State College of Medicine and PeerView for providing this session, and to AstraZeneca for providing the educational grant for this symposium. If you haven't already, please complete the pre-event survey. And as a reminder, look out for additional follow-up polling during the presentation. Submit your questions and we'll answer them during the Q&A session, or sometimes we'll answer them earlier than that. So please do submit questions. As much as we can make it interactive, it would be great. You can visit this event at peerview.com 2023 COVID-19, and the slides and practice aids are available to download. The goals for today are to provide you with a current understanding of the burden that COVID-19 prevention and disease have on the quality of life and activities of daily living of immunocompromised patients with hematological malignancies, to equip you to apply the latest evidence and guideline recommendations in the development of personalized point-of-care prevention plans for these patients, and to prepare you to integrate evidence-based strategies to overcome systems-level, physician-level, and patient-level barriers to accessing essential COVID-19 prevention methods. Kicking us off will be Dr. Gadi Haidar. He's an assistant professor of medicine, Division of Infectious Disease Transplant ID program at University of Pittsburgh. He's the director of research in the bone marrow transplant hematological malignancy and the ID program director, Transplant ID Fellowship, all at University of Pittsburgh. Dr. Haidar, come on up.
Thank you. Hi, everyone. Thanks for having me. So just by way of intro, so yeah, I'm a transplant infectious disease physician at Pitt. So the only patient population I see are people who are either post-transplant. Transplant is a broad word. It encompasses organ and stem cell and also CAR T, and also people before that. So our group takes care of all hematological cancers, essentially. So I want to start this by going over kind of the burden of immunodeficiency in the US and who's at highest risk for SARS-2 infection. So you'll see this number, 3% of adults in this country are immunocompromised, and it ends up being about 7 million people. So not a trivial proportion of adults, but not all immunodeficiencies are created equal. So we've stratified them here into kind of 3 different groups. The ones on the left with the light blue is the immune system doesn't really work that well, but probably not as immunocompromised as other individuals. Examples here include people with chronic lung conditions or people with uncontrolled diabetes. But then as the shades get darker, you get more and more immunocompromised. And so in the moderately immunocompromised group, that's where you start seeing individuals with solid cancers getting chemotherapy, people on immunosuppressive treatments, and individuals with advanced HIV with T-cell counts less than 200, and individuals who are on dialysis. But lastly, and what this conference and this talk is focusing on, is the severely immunocompromised patients, which includes organ transplants, really advanced HIV, and then in red, all the patients that this conference is about. So people with heme cancers, HCT recipients, people who are receiving treatments that get rid of their B cells, be it CD20 mAb or a CD19 CAR, and things like that. Next, there. And so the first thing I want to start with is that it's clear that people with heme cancers are at much higher risk of essentially all COVID-19 related outcomes than many other patient subgroups. So for instance, what we're showing you here is their risk for any infection. So they're more likely to get infected than individuals with solid tumors. You can see the hazard ratios here compared to people without any cancers. But, and importantly, the risk of developing any breakthrough SARS-2 infection is inversely proportional to the amount of vaccines that you received. So no vaccine is worse, 1 is better than no, 2 is better than 1, and 3 vaccines are better than 0. These are obviously older data. We're now in, I think a lot of these patients are now up to their 7th or 8th vaccine. But in general, the more SARS-2 vaccines these individuals receive, the less likely they are to acquire SARS-2. So it's not just infection, it's also hospitalization. And so what you're looking here is the risk of hospitalization by whether or not patients have no cancer, solid cancer, or heme cancer. And the heme cancer we've highlighted in this blue box, and the risk of hospitalization after COVID-19 is much higher than people with solid tumors and people with no cancers. And it's not just the risk of hospitalization, it's also the risk of death. And so across these groups, people with heme cancers, when they develop COVID-19, they are much more likely to die than individuals with solid tumors and individuals with no cancer. Now, the next few slides, I'm really just going to be showing you different iterations of these data just to really emphasize the point of how high risk people with heme cancers are for bad COVID-19 outcomes, and thus to emphasize the need to optimize how to prevent and also how to treat these infections. So this is a massive study out of England where they, through their National Health System database, they took a random subset of 25% of people, which ended up being about 13 million individuals, and then looked at those who were 12 years of age or older, so about 11 billion people, and then looked at COVID-19 outcomes. And I want to highlight that even though only about 4%, so 3.9% on this graph, of these patients were immunocompromised, they contributed to about a quarter of COVID hospitalizations, COVID ICU admissions, and COVID deaths. Meaning, even though the overall slice of the population pie, immunodeficient patients are only constitute 4% of that, they constitute about a quarter of all these bad ICU outcomes. And here's a more granular way of looking at these data from the same paper. And so over here, you're looking at the proportion of immunocompromised individuals who have been hospitalized for SARS-2, and they've divided them into kind of these broadly defined criteria, and then they've divided them into different kinds of subgroups. And you can see that the risk of hospitalization in people with blood cancers who have been undergoing treatment over the past 5 years is not trivial. I found it interesting, and this is, I think, the only paper I've seen where the risk seems to be lower than individuals with solid tumors. In reading this paper in detail, it seems as though these are really unadjusted and they don't account for things like age and comorbidities and vaccination and things like that, so you might wonder. But nonetheless, the risk of hospitalization in people with blood cancers is not trivial. And then when you look at ICU admissions, it's actually the highest when you start slicing the pie into the different categories of immunocompromised conditions that were defined in this study. And then when you look at deaths, it's also quite high. Again, I found it unusual that it seems to be lower than individuals with solid tumors who are receiving active therapy over the past 5 years. There wasn't anything clear in the manuscript to explain what this discrepancy was, but nonetheless, this just shows you that people with blood cancers are, again, very, very, very high risk for dying when they develop COVID-19. The other thing to mention about this paper is that it followed patients through December 2022. as in through the emergence of these XBB and BQ variants and things like that. And this is just a reminder that these individuals continue to experience bad COVID-19 related outcomes, even in the current era, when I think much of the population has dismissed these new variants as causing mild infection, which might be fair for everyone else, but for individuals like who are immunocompromised, these XBB and BQ variants and things like that still lead them to be hospitalized, go to the ICU, and unfortunately die. So we need to try to optimize this. And currently, really, the only ways to do that are to vaccinate and to mask. And everyone should be vaccinated, and Dr. Shoham, I believe, will go through the most current iteration of the CDC vaccine guidance. But it's not just the patient themselves, it's the cloud or the bubble that's around them, and so that's what we encourage the spouse and the kids and all of that to get vaccinated. And then masking, which I realize can be controversial, and the world has kind of moved on, but in my practice, the CDC and ASCO still recommend that immunodeficient people, including those with blood cancers, continue to mask. And it's also a recommendation that I still give when I see these patients. I still tell them kind of common sense advice of, I know you want to get on with your life, but just remember that the virus in you is going to behave differently than it might in your spouse, for example. So please try to remember to wear a mask if you're out and seeing people. And I think in my experience, most patients get it, and I haven't really received any kind of pushback about this from them, but I'm curious what you guys' experience has been with it.
So I'm of mixed emotions about masking, but my emotions don't really matter. What matters is the fact that a mask worn by a patient and a mask worn by their healthcare provider will reduce the chance of that interaction leading to an infection. So although when I go to the oncology unit where we have our most delicate patients, I must mask when I'm seeing those patients, and I don't like it, and I've had enough of the masking. Again, my emotions don't matter. What matters is that it will make a difference, not a huge difference, but a difference, and for that reason, I do it.
Dr. Huff?
Yes, so as Dr. Shoham said, we do require masks in our oncology center, both for patients and for healthcare providers. And I do recommend to my patients masking when they're out. I do encourage them to do things and live their life, but to mask and to be cautious and to be vaccinated and have their cloud vaccinated as well.
And from a health system perspective, our system a few months ago basically got rid of universal masking, except for all the heme cancer wards and all the organ transplant wards, which all have big fancy signs and also masks up front when you enter the unit. All right, so a quick segue into what SARS-CoV-2 does and what to expect about natural history of the infection. And I will walk you through this. So just look at the lines first. When the red graph is the viral load. So you start getting infected where my mouse is over here, and then the viral load kind of goes up, 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 up. It peaks. You continue to shed for some duration, a week or two, and then eventually the virus goes away. While that happens, you begin to mount an antibody response. So the blackish, blue, and orange lines are all antibodies. Your spike IgGs might peak. You will neutralize the virus for some time. Your IgMs will go away. And this is, I think, standard for many, many different kinds of viral infections. And then the course of the illness, if you're going to get really sick, will generally progress in a stepwise fashion from asymptomatic through critical, and then some people unfortunately get long COVID. This applies to immunocompetent people. And I think you'll hear more about this later, but with immunocompromised individuals, some immunocompromised individuals, the ones who are severely, severely immunocompromised, This is where you'll see this red line of SARS-CoV-2 active viral shedding lasts for months, if not a year or longer. This is where the virus can evolve within the host. And this is where, despite months of active infection, these individuals simply never mount an antibody response. And I've seen this just anecdotally a lot in CAR T-cell patients who have positive swabs for over a year, and it's the same virus evolving. And so how to treat? The general concepts are similar across immunocompetent and immunocompromised individuals. There's some fine print about immunocompromised individuals that you'll hear about later, but we've divided this into, so the first 1, 2, 3, 4 rows are direct-acting antivirals, which are remdesivir, nirmatrelvir plus ritonavir or Paxlovid, molnupiravir, and convalescent plasma. And remdesivir is indicated for people who are hospitalized, and all the others are generally, and the oral agents, so Paxlovid and molnupiravir, are recommended for individuals with mild and outpatient disease. There are people looking into Paxlovid, for instance, for inpatient treatments. It does appear to be a potent antiviral, but not currently approved for that. And convalescent plasma does, or probably does, have a role in individuals with B-cell deficiencies, and there are data supporting its use in blood cancer patients, but there's lots of logistical and operational issues to consider there, including getting it in a timely fashion and making sure you have high titers and things like that. Dr. Shoham, do you want to expand a bit on CP?
Sure. So the concept behind convalescent plasma is that it's a passive immunotherapy similar to the monoclonal antibodies, except that convalescent plasma is produced by people that have resolved the infection as opposed to produced in the laboratory. With the current technology and a current know-how, the units that are available now are overwhelmingly going to be people that have had infection and been vaccinated, so the antibody levels are very high. However, the logistical hurdles to getting it to patients can be significant, particularly in places that haven't used a lot of it and don't have the system down. So it has a role in patients that can't make their own antibodies, but if a direct-acting antiviral is available, such as remdesivir or Paxlovid, then that's going to be your go-to.
Thanks. And so remdesivir, works well to keep people out of the hospital if it's started early and given within the first few days, but there's logistical considerations there because it's 3 consecutive days of an outpatient IV infusion, which can be difficult to do. And Paxlovid, as a reminder for everyone, has a ton of drug interactions because of the ritonavir component, which is a pharmacological booster. It's a very, very, very potent CYP3A4 inhibitor, lasts in your system for a while. And just remember not to prescribe Paxlovid in a cavalier fashion. Make sure you know what other meds they're on. If they're on a calcineurin inhibitor, for example, for GVHD, and you prescribe Paxlovid without a CNI monitoring or interruption plan, the patient will develop toxic levels, PRESS, AKI, and things like that. And remember, too, that it also takes a few days for the Paxlovid to wash out of your system. So those are some of the practical considerations there. Now, the lower 3 are the immunomodulatory agents, and these are given generally with more severe disease. Steroids should really only be prescribed in people who are on O2. But then you get into the IL-6 inhibitors like tocilizumab and the JAK inhibitors like baricitinib. And in general, the COVID treatment guidelines do recommend them for people who are actively deteriorating and with severe disease. I personally worry a little bit about using them in a non-judicious fashion in severely, severely immunocompromised individuals. And I worry at times that it might exacerbate the infection if we think they have active infection or might put them at risk for OIs. But these cases are very challenging, and I try to be judicious, let's say, if I see a CAR T-cell patient with very severe COVID, and it's always a difficult decision about whether or not to give them toci, but I'm curious to see what you guys' approach is with drugs like toci for severe COVID in this population.
Yeah, I think that the point that you make is that using a baseball term, these patients are often already standing on second or third base, and adding the steroids even, or tocilizumab or baricitinib, or a combination of all those, just gets them closer to having a devastating superinfection, aspergillosis or other infections. So I worry about all that. If they need it, they need it, but it requires, I think, a thoughtful decision-making, not just following a guideline.
Dr.
I
Huffs?
was just
Yeah.
going to say that usually it's a multidisciplinary,
Yep.
team-based consideration of all aspects of it, and there's not a one-size-fits-all. So it's a collaboration between the hematologic malignancies physicians, the infectious disease team, and the pulmonary critical care team, and an individualized decision.
All right. Now, going back into the issue of COVID-19 vaccine responses, and I did see a question in the chat about who's at risk for responding or not. So the bottom line of this slide is that people with hematological cancers don't mount a decent antibody response to SARS-CoV-2 vaccines. And so the graph on the left is actually some work we've done where we followed a large cohort of immunocompromised individuals and measured spike IgG antibodies after 2 mRNA vaccine doses and then after 3, and just kind of looking at how the antibody levels change. So on this graph, this solid line at the 1 is the distinction between an antibody positive, which is above it, or antibody negative, which is below it. And on the x-axis is the different type of immunocompromised group, with HCW as a healthcare worker being the reference. So you'll see HIV, organ transplant, et cetera, and heme cancer highlighted over here. And what's in blue is the antibody level after the second dose. What's in orange is the antibody level after the third dose. And I think everyone can appreciate that basically all the orange graphs are kind of up, so the antibody levels kind of boost with everyone after they get dose 3, which makes intuitive sense. But you will also appreciate that in the hematological cancer patients, still probably most of them fall under this this line of seropositive. So they start low after dose 2, and even though they boost, they boost much less robustly than everyone else. And the only other individuals who performed as poorly were organ transplant recipients. So, and it's now known that people with blood cancers may not even mount an antibody response up to 4, 5, 6 vaccine doses. This forest plot just shows you pooled study data, and this nice little diamond in red below to the left of the line shows you that, again, people with blood cancers tend not to respond to antibodies, to vaccines. There's a poll that you need to answer, please, before we move on.
And while people answer it, there was a question that came through regarding whether antibody titers should be checked after vaccination, something we do in hepatitis B, for example.
Yeah, this is a very controversial topic. So the CDC, ASCO, NCCN, and the American Society of Transplantation, and the FDA, still to this day, do not recommend for the routine measurement of antibodies after vaccines in order to help with clinical decision making. And in my practice, I don't do it. And the reasons I don't do it are the actual titer you're going to get is going to vary by the assay you use. So Quest, LabCorp, or your home assay might the same serum sample will give you a different titer. We don't know what the titers are that are protective versus Hep B, where we actually do know this. Protection is actually a moving target. that is going to vary by the predominant variant. And so a positive antibody in someone who received the original monovalent mRNA vaccine in 2021, even if that level is, let's say, 1 million, it probably won't do anything against the current E variants, for example. And it's also a moving target. And so it becomes, is this going to be a binary decision? I'm checking your antibody today, and yes, you are good, or do I have to keep checking over and over and over and over again and kind of see what the trend is? And so for now, I don't do it because of all these reasons. I know that some centers and some individuals do it. I think that if there's a benefit, it might be in people who are seronegative persistently, and then you can just use that to counsel them that, hey, you really, really are at risk for SARS-2. And we also mustn't forget about T-cell responses, where there's some data to show that in some people at least, there's discordance, meaning that they can mount a T-cell response without an antibody response.
Great, thank you.
Do I move on, or?
Yeah, please do.
All right, so masks. This is just to reiterate what we had said before, that masks will work if I'm wearing a mask and my patient with a CAR T-cell is wearing a mask, and let's say I have COVID and I don't know about it, the chances of giving them COVID are reduced if we're both wearing a mask. And this risk of developing SARS-2 will vary by the kind of mask that you're actually wearing, with cloth being worse than surgical, being worse than N95 masks. But when I counsel them, my stance is something is better than nothing. So I try not to be too dogmatic about the kind of mask. Is this you guys' approach? Yeah. Yeah, I've never told someone you have to wear an N95. I just say, just please wear a mask. And I think most people I've seen just wear a surgical mask. So we have vaccines, which may not work that well. We have masks, which work, but we need to do better. But unfortunately, there's really nothing else at this stage. At some point, we had tixagevimab and cilgavimab, which was a monoclonal antibody for pre-exposure prophylaxis, not authorized anymore. And at some point, we had these 2 other mAbs for post-exposure prophylaxis, but not available. And the reason none of these are available is because we had new variants emerged that were resistant to them. But just as a reminder of what tixagevimab cilgavimab is or was, it's a SARS-CoV-2 monoclonal antibody that binds to the spike protein. And between end of December or mid-December 2021 and end of January 2023, it was authorized in the US for PrEP, or pre-exposure prophylaxis, of immunocompromised people against COVID-19. It really wasn't meant to be a substitute for vaccination, but it was meant to kind of help prevent SARS-2 in people who we think may not mount an antibody response. There were various dosing changes, but ultimately the final dose was a total of 600 milligrams given IM, and it was a safe drug. There really were no issues with it. Now, this drug, though, was authorized based on a study called the PROVENT trial, which was conducted, I think, before anyone knew anything about how poorly immunocompromised people would suffer from COVID-19, and so it enrolled largely immunocompetent people, but was then authorized for use in immunocompromised people. And so there's hundreds of retrospective cohort studies looking at its real-world effectiveness, and it does seem that while it was authorized and while the circulating variants were susceptible to it, it worked. It prevented people from getting COVID, and it prevented people from dying. So this is a big study from Israel where they really only looked at immunocompromised individuals. You will see the ones who had CLL, the ones who had received an anti-CD20 in the past 6 months, which was almost 45%, a few BMTs, few CAR-Ts, and then lots of lymphomas and myelomas. This first graph here shows you the risk of breakthrough infection, and the second graph here shows you the risk of death from COVID-19, stratified by whether or not they got tixagevimab and silgavimab. So the gray is the individuals who didn't receive it, and the black is the individuals who did receive it. The black lines are much lower, meaning that silgavimab really prevented breakthrough infection and prevented death while it was available. And there was another meta-analysis that also showed that, yes, it was effective against breakthrough, effective against hospitalization, effective against ICU, and also effective against mortality in about 92% of individuals, but we don't have it anymore. And the reason is SARS-2 is a very plastic virus, evolves really quickly, and soon after tixagevimab, silgavimab was authorized, you have the emergence of novel variants. And so with this first graph, you're looking at neutralization against BA.4/5. And so what this group from Canada, I believe, did is that they got serum from individuals day 0, and that before they received Tixil, and then they got serum again 3 weeks after receiving Tixil, and they looked at how well that these two sera can neutralize different variants. So with BA.4 and 5 on day 0, some people did have some neutralizing activity. Perhaps they'd been vaccinated before, but you can see that there's a ton of circles at the bottom, meaning that they had no activity. Then 3 weeks later, everything kind of moves up, meaning that after getting injected with Tixil, their serum now inhibits the BA.4 virus, which was dominant for some time last year. But then when they did the same experiments looking at BQ1 in orange and XBB.1.5 in greenish, you will see that the graphs didn't really budge. They are the same, meaning that Tixil didn't neutralize these two variants. And as soon as over 90% of the variants in the US were resistant to Tixil, the FDA revoked its authorization. But this is not the end, because there's actually a next generation of it with a trial focused only on immunocompromised individuals that you'll hear about later. But now I think there's a patient story.
Hello, everyone. My name is Halis Simi. I am a CLL patient, but I also am a facilitator for the Patient and Care Partners Support Group in the state of Oregon and part of state of Washington. Additionally, I serve on the Patient Advisory Board of CLL Society, where we shape the patient's experience and advance awareness of the chronic lymphocytic leukemia. My health journey started in 2007. I noticed some bruises on my body, and I had a big lymph node in my neck. Unfortunately, my physicians dismissed the symptoms till finally in 2009, a new doctor diagnosed me with CLL. And I have been on watch and wait status ever since. I think the burden of COVID-19 prevention on immunocompromised patients is significant. It's affecting their mental well-being, their daily activities, and overall quality of life. And you lose hope, and you lose sense of well-being, and it affects me, and it affects your loved ones, the people around me. My husband is constantly in fear that he goes out, maybe he's gonna bring me something. I wanna go see my kids, but I can't travel much. And all of these things really make you isolated. I mean, what's life without, seeing your loved ones? What's life without socializing, being with your friends? And I'm missing a lot of moments that it cannot be repeated. It's very important for immune-compromised patients to be proactive about COVID-19 prevention, because if you're immunocompromised, you could have severe illness, as I did a couple of years ago. The most important thing, even though we don't make enough immunity, is vaccination, and keep up with the vaccination and booster shots.
All right, and now Dr. Shoham.
Thank you. Okay, so Shmuel Shoham, I'm a professor of medicine at Johns Hopkins, and I will talk a little bit about something old and something new. So we'll start with let me see if I can. There we go. We'll start with the ACIP, that's the advisory body to the CDC, the recommendation for vaccination for immunocompromised patients. And there's probably very few people that are unvaccinated, but in the view of a hematologist or an infectious disease, somebody who's undergone CAR T cell therapy or somebody who's undergone a stem cell transplant, we will consider those people as unvaccinated, and therefore they should be revaccinated. And what does revaccination means? If you're using an mRNA vaccine, it's 3 doses, whether it's the one by Moderna or the one by Pfizer. If you're using a subunit vaccine, which in this country is the Novavax, then that's a couple doses, and that's somebody who is considered unvaccinated. And then for somebody who's been previously vaccinated, then if they've had a dose of the mRNA vaccine, then they get a couple doses of the mRNA vaccine to catch up. If they've had a couple doses, then they get 1. And then if they've had 3 or more doses, they still get another one with the boosting that we have, whether it's the Moderna or the Pfizer or the subunit. And you do not need to memorize this slide, but it might be good to have it handy, and you can either have it, take a photo of it, put it on your phone, or you can go to the CDC, and they have this slide on the CDC website. There are some caveats that I'll get into with these recommendations, and that's for some of the patients that you deal with every single day. So, for example, a patient that has received a stem cell transplant or CAR T therapy, then if they've received 1 or more doses of the vaccine prior to treatment, as I mentioned, they should be revaccinated at 3 months after transplantation. And I'll get into some data as to why we say 3 months should be fine. If a patient's received 1 or more doses of the COVID vaccine during treatment with a B-cell depleting therapy, such as rituximab or something of that nature, they should be revaccinated about 6 months after completion of that therapy. Probably 9 months would be even better immunologically speaking, but you have to try to balance the wanting to get a vaccine product into a person versus the perfect antibody response. Sort of, you don't want the perfect to be the enemy of the good. So at 6 months is going to be a minimum of when you want to revaccinate them. And then if it's somebody that is getting rituximab again and again and again, then, well, you can't keep vaccinating them again and again and again with each rituximab therapy. So you choose sort of the next one that's coming up, and then 4 weeks before that one, give them the vaccine. All right, please answer the following question before we move on. If I could whistle, I'll whistle Vivaldi's Four Seasons while you do it. But and now for a little bit of science about antibody responses. So picking up on what Dr. Haidar mentioned, that the antibody responses are not ideal in patients that are immunocompromised and getting vaccinated. Here is a study from 174 allo BMT patients that were vaccinated. Some of them were vaccinated less than 4 months, and some of them were vaccinated 4 to 12 months after transplant. And 57% of them, so not a tiny number, most people did achieve a antibody spike level at the end of the vaccination series. They received 3 vaccinations or sometimes even more. And as you can see, progressing, the antibody level initially, for those that got vaccinated within 4 months of transplantation, and those that got vaccinated at 4 to 12 months after transplantation, initially the levels were better. In the later transplant people, the later vaccination period, sorry, take that, the earlier vaccination, but that number caught up pretty soon, and then there was no difference in antibody level, mean antibody level, whether they got the vaccine early after transplant or at 4 to 12 months after transplant. So from that, I'll say that vaccine timing, 3 months after bone marrow transplant, unless there's something really dramatic going on with their immunosuppression, if they're getting anti-thymocyte globulin or rituximab or some massive immunosuppression, 3 months after transplant should be a fine time to vaccinate them. And whether they've had prior GVHD or immunosuppressive antibodies and immunosuppressive medications or not, doesn't seem to have a huge impact in this study on the antibody titers. So with all the limitations of what antibody titers mean, the bottom line is data support vaccination 3 months post-transplant. Here's a patient example, a 65-year-old woman with CLL, hypogammaglobulinemia, received the full COVID vaccination series plus several boosters, still masks in public, avoids crowds when possible, and as the world returned to normal, she's finding it difficult. Everybody sort of moved on, but she doesn't like to be in crowds, but can't avoid it altogether, can't always mask, and she's worried about getting COVID. This is, I think, a lot of your patients are like that. So back in the day, a couple of years ago, we had something that we could easily give her to help things, and one of my cousins is actually a recipient of this, which is a monoclonal antibody for prevention of infection. And picking up on what Dr. Haidar was saying, multiple studies put together, you can see that the overall effectiveness for preventing coronavirus infection, and that is anything from sniffles to being in the ICU, was about 40%. But when you look at prevention of hospitalization, then you get up into the closer to 60 to 80%. So putting that all together, the stuff was working when it was effective. But as we know, the virus mutated on us, and the monoclonal was no longer working. This is a study from Israel, sort of a complementary study to the study that Dr. Haidar was mentioning, where again they looked retrospectively at the risk for infection in immunocompromised patients, and this was a diverse group of immunocompromised patients, and you can see that there's a split in the patients that had the control versus patients that got, I'm going to use the term Evusheld, which is a trade name, not because I'm trying to sell. Evusheld can't sell it, doesn't exist anymore, but just so I don't have to pronounce that long name. And you can see that there was a difference when they looked at the subgroup of patients that had an impact. So overall impact, there was an impact. When you looked at the subgroup, it was interesting in that the patients that had malignancy in the prior year, actually it didn't have an impact in terms of preventing infection altogether, again, sniffles all the way to ICU care. When you homed in on hospitalization, again, a difference between risk of hospitalization, getting the Evusheld versus the control. They, in their analysis, and I went through this study up and down, they didn't actually include oncology patients in their subgroup analysis. So I don't know if in that subgroup, it's probably that they didn't have enough patients to really home in on subgroup of patients that had both cancer in the past year and required hospitalization, whether they got Evusheld or not. But again, the whole group, there was a decline. So putting this plus all the other stuff that we know about Evusheld, I think when it was available, it worked. Wasn't a perfect shield, but it did provide some protection. And what this study showed is looking at homing in on patients with B-cell malignancies that received Evusheld, and they had a lower risk of infection. And here we're in a group, 224 did not get infection, 27 did get infection. In this subgroup where they were trying to look at, did they need the 300 and 300 versus the 150 and 150 doses? And I don't think they had enough number to really make this call. So they didn't see a difference, but I don't think they were powered to show a difference regardless. So I think I'm still going to go with the 300 tolerable and lots of antibody to provide protection when the stuff was working. But we now know that it stopped working. Another approach, which is not what we used in our hospital, listening to Dr. Haidar, not what's used at Pitt, was to check antibody level. If their antibody level was low, then either give them Evusheld, give them Evusheld and see if you can prevent it. If their antibody level was high, then monitor them alone, saying, okay, well, you don't need to give them additional antibody. They already have their own antibody, with all the caveats that we don't really know what the magic number of antibody is to provide protection. And in that particular study, they didn't have a difference in outcome from the two different approaches. We have not used this approach. I present it to you because I think it's an interesting strategy, but we didn't use approach. This is something from our center that my colleagues, Dr. Karaba and others, showed from solid organ transplant patients. So not exactly applicable, perhaps, but what was interesting was that the level of antibody that the patients had that was able to cause inhibition of the virus using a system called ACE2 inhibition percentage. When they looked at the ancestral, the original COVID, great protection for many months, but as the virus mutated to more advanced viral subtypes such as Omicron BA.5, the efficacy waned so that maybe a 6 months vaccination, Evusheld therapy, Evusheld was given at month 1 and then again at month 6, but it looked like the activity for some of the Omicrons had waned, so that perhaps giving it more frequently would have been more effective. It's just something to keep in the back of our mind as we look at new products, whether the every 6 months is going to be enough or whether it'll need to be given a little bit more frequently. So where are we today? If you go to the NIH guidelines today, the panel recommends against anything for pre-exposure prophylaxis, whether it's Evusheld or hydroxychloroquine or chloroquine or ivermectin or vitamin D or anything. They don't recommend it. That's not to say that if somebody needs vitamin D for other reasons, you shouldn't give it to them. But there's no recommendation for anything for pre-exposure prophylaxis right now. However, there are some emerging antiviral agents, and at top of that list is AZD3152 for pre-exposure prophylaxis. It's a monoclonal antibody that I'll talk about a little bit later. It's now in phase 3 studies. There's another monoclonal antibody that is VYD222 that's in phase 3 study, both for pre-exposure prophylaxis and post-exposure prophylaxis, and a series of other drugs in development. One of the more interesting ones in my mind is VV116, which takes remdesivir and has done a little bit of modification to it so that it can be taken by mouth instead of by IV. Paper in New England Journal of Medicine describing that. I think there'll be some new products hopefully coming soon for prevention and for treatment. Take a minute to answer the next question.
So while they do that, just a couple of questions that have come through. So one of these questions is in the prior monoclonal antibody rollout, patients with CLL on a watch and wait were not considered eligible for monoclonal antibody prevention. Will this change with the next generation monoclonal antibody rollout?
I hope so, and I hope it depends on the patient type, and that if you have somebody with CLL that particularly is hypogammaglobulinemic, I would love to give that person something, because I'm going to give them the antibody, the vaccine, and they're probably not going to get a great response. On the other hand, if it's somebody that is much more immunologically robust, then maybe less critical.
Yeah, and I'll just add to that Can people? Yeah, and I'll just add to that that so these individuals were actually eligible. The EUA in the U.S. included a wide spectrum of immunodeficiencies and was a little open to interpretation, which really helped. So people with CLL were eligible, but I think it depends on your institution and supply and protocols and things like that. I'll tell you at our site, when we initially, and you'll hear more about this by Dr. Huff, but we initially restricted Evusheld when supply was really low to quote-unquote highest risk people. So that would be a recent CAR T, a recent stem cell transplant, or a recent lung transplant and things like that for about 2 months. And then after that, we started opening it to all others. But at our center, people with CLL on observation were definitely eligible and received Evusheld.
And I would just say, I think this question illustrates the challenge of what was present and hopefully won't be present in the next generation, which is this variability across the country, across centers, which was largely, I believe, due to supply and availability, but this interpretation of these aspects. And so there were certainly places that had greater availability and greater ability to administer it, and other places where that was more difficult. I know there was also a question earlier about access in rural communities, and I'll touch on that a little bit in the next section as well.
Great, thanks. So moving on to one of the new drugs that is in development, AZD3152. It's the next generation of Evusheld, but instead of 2 monoclonals, it is 1 monoclonal. It was derived from B cells of patients that had COVID and convalesced from it, and then this particular antibody was derived from it, as were all the other monoclonals that we used. Those were antibodies that were derived from patients that had improved. 6 months protection is expected, and there's a this is the what the antibody looks like, and this little area, this little island here, binds to the ACE2 binding site of the virus. So hopefully that's where it binds. When the person gets the monoclonal antibody injection, it's in their system for weeks and months. They encounter the virus. Before the virus has a chance to really cause a lot of damage, this monoclonal binds to the ACE2 binding site, impairing the interaction between the virus and the epithelial cells, the respiratory epithelial cells, and the patient then does not get infection, or if they get infection, it's not as severe. How long does it stay in the system? This is a poster from ID Week in October, and initially when you get the injection, then you get very high levels, and then they start going lower, and you'll see the blue is what was one of the active ingredients in Evusheld, and the orange is the active ingredient in this medication. They gave it IV and IM, but it looks like it's not a huge difference in terms of drug levels. But the point is that it starts waning, and will an every 6-month regimen be effective? I think the study is ongoing now. Will we learn post-marketing that maybe it needs to be given more frequently? To be seen. At this point, the target is that at 6 months, you're still expected to have enough antibody that's effective against the circulating variants. Whether the variants will then change, meaning that the stickiness of the antibody isn't as good, the fit isn't as good, and maybe you need higher antibody levels and therefore more frequent dosing, that's to be determined. But the information that we have right now is that we think that every 6 months should be okay. A little bit more about this product here. It was given to animals, and in this side, you can see at day 3 and day 7 of an animal that did not get the AZD3152, but did get an infection, that there's a lot of inflammation going on. On the other hand, a patient that got it and then was infected, didn't have as much inflammation. So it is protective in actual animal models. In terms of in vitro, how active is it? It looks like if you have high antibody levels of it, which you should expect with the dosing that's now recommended, that it will be active against all of these various variants. So good activity against the variants that are out there. But there is one troubling variant here, which is very uncommon right now, but it is a small but not 0% of the viruses that are out there, where the dose, the IC50, which is sort of how effective the killing is, the lower the number, the better, is pretty high for this one. So it's not going to protect against all the variants out there, and I think if XBB 1.5 with the F456L mutation becomes dominant, then it'll tell the same. We'll be telling the same story that we've told about other monoclonal antibodies for viruses, in that resistance develops. We don't know that that's going to happen. We hope and pray that it doesn't. But I don't want to tell you that this is going to be good forever, because it might not. There is a trial that's ongoing right now. It's called the Supernova trial. It's a phase 1 to 3 trial. The phase 2 is the one I'm going to focus on. The goal is to establish safety and efficacy of intramuscular AZD3152. It's being given at 1-to-1 placebo versus the drug. Initially, some of the patients didn't receive placebo, received Evusheld, which essentially is placebo because it's not active against the circulating variants. But then at some point it was decided, okay, we're just going to change it to placebo. Why give you Evusheld when we can give you placebo, since the Evusheld isn't going to do anything? It's given at 1 month and 6 months. Primary endpoint is safety and neutralizing activity of a single IM shot. So whereas Evusheld was 2 shots of 300, this is just 1 shot. That's another reason why the comparator was switched to placebo, is that patients are getting fewer shots. They don't need to get the 2 shots. And we're waiting on the results of those. I don't have a results slide on that. We were hoping that by the time this conference came, we'd have some results slides to show you that it's safe or not, effective or not, but not quite there yet. So where are we today for prevention? It's still vaccination. It's still non-pharmacological intervention, and then when the patients have infections, then we treat them with the approach that Dr. Haidar spoke about. One thing that he did not speak about, but he touched on a little bit, and I'll dive in a little bit further, is the concept of protracted COVID. So these are patients, I'm sure some of you have seen these patients, where they develop COVID and then they're stuck in sort of COVID jail. They can't clear their virus. Some of them get sicker than others. Some of them get admitted to the hospital a few times, maybe touch the ICU, and then come out, and they just cannot clear the virus, cannot get back to their life. Who are these patients? They're more likely to be lymphoma patients, some myeloma patients, some transplant patients, CAR T patients, and patients that have gotten rituximab. I've found that that's oftentimes rituximab is somehow in the mix as well with these type of patients. There's some diagnostic criteria that my colleague, Dr. Dioverdi, and my colleague, Dr. Haidar, established, and you can see them here, and that you may encounter some of these patients with protracted COVID. There's a chance for a question.
While that's happening, let me ask you.
Yeah.
There was a question. I mean, maybe you can speculate. You know, with These new variants being the Achilles heel of many of the monoclonals, do you think it's a sustainable approach to try a new monoclonal every year? Is your sense that this might turn into something like the flu shot, where you don't have to launch these massive trials every single time? What is your sense about all this?
Yeah. So I think monoclonals. So I'm going to take a step back in that there's been 3 ages of infectious diseases in the antibiotic era. There was the passive immunotherapy era, which came initially, and where people were injecting animals with microbes and then generating antibodies and then giving it to people, or people were taking convalescent serum or convalescent plasma. That became inconvenient when the small molecules, penicillin, sulfa, and others came, which blew it out of the water. And then when we've come to the 3rd age, where we realize that there's some conditions where there isn't a small molecule available, and then so we go back to passive immunotherapy with monoclonal antibodies or with polyclonal antibodies. But what we've learned with the monoclonals, with the 3rd age, is that variants do happen, and particularly for viruses that I'll call sloppy RNA viruses that are just mutating all the time and are changing themselves, so that you develop a monoclonal. It's not like a monoclonal against CD20, which is just going to be stable forever. It's a monoclonal against a changing target. I think it depends on how important that target is to the virus. If it's a target that it can't do without, then I think the antibody is going to be more long-acting. If it's an antibody that the virus is just very happy to mutate and go along, then we are going to need new antibodies. One of the questions that I don't think is answered is, do treatment with monoclonal antibodies, are they acting in parallel with mutation? Is the mutation happening because of the interaction with the virus and an immune system, or is the interaction happening in people that have gotten the monoclonal and it's becoming resistant to that monoclonal and then taking over? I tend to think that it's more the former than the latter, because a lot of the mutations are occurring in places where they're not using a lot of monoclonal antibodies. But I will say that we don't know where those mutations are happening. We know that they're detecting them in South Africa, but did they happen maybe in a place where they were giving a lot of monoclonals, and then because of the excellent virology labs in South Africa, that's where they detected them? Unknown. So I think the short answer to your long question is, I am worried about the durability of monoclonal antibodies against the sloppy virus. Just finishing a little bit about the issue of protracted COVID. So we're going to enter here a data-free zone and how to treat those. But here are some of the things that we've done. Is we've given Paxlovid, which is ritonavir boosted nirmatrelvir, for longer than the 5 days. We've given remdesivir for much longer than the 5 days, 10 days or even longer. We've done mix and match, where when we had monoclonal antibodies that were effective for treatment, we used those plus a small molecule like remdesivir or Paxlovid, or we used convalescent plasma plus those, or I've seen dozens of paper out there, single case reports of places where they're using, say, remdesivir plus Paxlovid. So mix and match. I think that if you have somebody who's sort of caught in this viral prison, then you want to give an antiviral, and so a combination antiviral sounds like a good idea to me.
Would you just comment, I know the perspective, but would you just comment on where you would use molnupiravir versus Paxlovid?
So where I would use, what was the first part?
Molnupiravir.
So molnupiravir is another small molecule antiviral, and it doesn't have a great track record in terms of the clinical trials, and it also is mutagenic, which maybe with all the other stuff that these patients are getting, that's not the biggest concern that it's mutagenic, but it's a concern. So I tend not to want to use it as my first line, and if I have an option, I'd use Paxlovid over it. However, Paxlovid has ritonavir in it, and sometimes you feel like you need a PhD in pharmacology to figure out all the drug interactions between ritonavir and some of the other drugs that the patients are getting.
But the preference would be Paxlovid or remdesivir as your frontline therapy, and
By far.
By far.
By far.
So just to be clear for.
Yeah, I think that's a great point, is by far. Sometimes we use molnupiravir, but I don't like it. All right, patient story.
In December 2021, I had COVID. In January 22, they admitted me to hospital, and I had a really difficult time. Therefore, when I came out of the hospital, I started searching into preventative cares for and other medications that could help me with preventing COVID. I came across the monoclonal antibody, and unfortunately when I went to my primary care physicians, he didn't know anything about it, and I had to even spell the medication for him. He gave me a prescription, and I took it to the pharmacy, and they laughed at me. They said, this medication is not available like this. You have to go through your oncologist. He's the only one who could help you. I went to my oncologist and I asked for it, and he said that his hands are tied. He cannot prescribe the medication for me. It's on a waiting list. It's such a high demand and low supply. I was not inside that pool because at that time CLL patients were not considered immunocompromised or priority enough, and especially somebody like me that has been on watch and wait status. Finally, the pressure on all these physicians and oncologists, which they knew that some of these patients, they need this medicine. They found a clinic in Salem, Oregon. I live in Portland, Oregon, but they found a clinic in Salem, Oregon, a small clinic that could give the extra doses they had to their patients. And they put my name in the list in January 22. Finally, by June, they called me 6 months later to receive the injections. So I waited till June 22, and I had to drive 2 hours to Salem, Oregon, and I received the injections, and it was wonderful because it gave me a sense of relief that now I have an extra layer of protection, and it gave me hope because it reduced the risk. After I got the injections, I was able to attend 2 weddings, which was the best thing happened to me after being isolated for so long, after being lonely and fearful. I was able to see many family and friends, and I went in January, and I had my second dose of monoclonal antibody injections in the same clinic, and I was able to take my daughter to Europe and Italy. I promised her to do that when she graduated in 2020, but finally this happened, and it was the best trip of my life.
Wow. Dr. Huff, come on up, do the handoff. Try not to kill you while you're doing it.
All right, so thanks very much. So I'm going to talk a little bit about the tactics for trying to improve our ability to administer these therapies to our patients. And I think many of you in this room have probably experienced the challenges, the limited capacity that we found in some states versus other states having a greater surplus. We've heard from our patient who had to wait 6 months to receive her Evusheld. The system is complicated. These were allocated by the federal government and given to states on a monthly basis. And then institutions had to figure out how to roll these out. And lots of meetings and lots of discussions as to prioritizations, and the criteria weren't the same around the country. I mean, there was people who were eligible, but not every institution had the ability to allow all of the eligible patients to receive this. There was also lack of patient and clinician awareness, both of the agents, but also how to access these agents. Both due to locality, due to socioeconomic status, and due to lack of access to technology. And I will show you that there's actually data that really there was continued disparities in patients being able to receive and access these therapies, both preventatively and therapeutically for patients with COVID-19 receiving these antibody-based approaches. And so looking at the studies of allocation of these resources, Black patients were about 25% less likely to receive monoclonal antibody and anti-COVID therapies than white patients. Asians were about 50% less likely than white patients to receive these therapies, and other races, 46%. And there are a multitude of reasons behind this, but clearly these disparities were present. If you ask patients, and I'm sure many of you in this room could certainly attest to these statements that people have said, they want us to keep them up to date, to keep trying to find strategies for them to help prevent these infections, make these medications available to them, help them understand the risks and the benefits of these therapies, and make it easier, not just for COVID therapies, but for lots of things that we do for our patients to make it easier for them to access these things. And so the question being, which patients are candidates for these next generation preventative agents? We believe that similar to patients who are eligible for the older agents, but hopefully this will expand and the availability of these agents will expand, and that we'll be able to give them much more broadly. And I sincerely hope that that's the case. I believe that's the case, as these will be generated by the pharmaceutical industry and hopefully disseminated in that manner rather than a limited supply that we had previously. But again, with all the caveats of continued mutations and evolution of the virus and the efficacy of these, but just being able to give these to our patients. And the list of immunocompromised patients is here. I think we all recognize clearly that patients with hematologic malignancies, B-cell directed therapies, and the strategies for treating these are some of the most immunocompromised patients, certainly here. Solid organ transplant patients as well, in all the graphs that you've seen, are the ones that have the highest risk and the lowest likelihood of responding to our other strategies. So these will likely be the patients who will be eligible for these next generation preventative agents. There are many resources out there, but this one in particular is to really communicate with patients about their immunocompromised status and their need for extra protection. So the CDC websites have quite a bit of information on guidance for planning, prevention, testing, and exposure and treatment for patients that are immunocompromised. And really making plans ahead of time with patients. So as time has passed and people have overall done better, we still have our patients that are getting severely ill in the setting of COVID infections. And so trying to make sure that patients have access to the information that they can help protect themselves and know when COVID is rising cases in their area using these tools that are available. One of the questions that was actually asked through the question and answer was, how do you help reluctant patients? And so this is a patient, Colin, who's a 62-year-old gentleman with myeloma who had a bone marrow transplant 2 months ago, had preceded by 4 months of chemotherapy. And you're trying to educate him and give him guidance, and he is somewhat hesitant about, he understands our concerns, but he's somewhat hesitant about COVID-19 prevention. And so some of the strategies that I've employed is really to try to understand and listen as to why he might be hesitant, and try to provide information and counter any misinformation that might be available. You've heard from Dr. Shoham and Dr. Haidar about the safety of these treatments, at least the ones that we've had to date, with really minimal side effects and benefits that we've seen, reduction in hospitalizations, reduction in death associated with it, and so really trying to educate our patient. Someone who's only 2 months out from a transplant would not be eligible yet for immunizations because remember, we would start those at 3 months post-transplant. So if we were to have a COVID-19 prevention strategy and therapy to offer, this would be a patient that we would certainly want to do so. And so many times in patients such as this, it is ongoing discussions. It's not one visit, and it's a topic that you can continue to readdress. And I have had success with patients like this that with continued information provided in an open and collegial and discussion way, moving the needle and getting patients to be accepting of that. So it's also helpful to have all of the staff understanding because many times patients are more open in speaking with the nursing team or our pharmacy team than perhaps physicians, and so having everyone be able to educate our patients is very helpful. I think one of the important lessons that really is we need to ensure there is access to these emerging agents for all patients. There are some tools available. There is the therapeutics locator that is actually up to date if you haven't gone to it. I actually still look at it when I'm trying to identify therapies. Paxlovid is now largely commercial, but you can still find the pharmacies that have it and what they have on hand. So at the website that's listed here, and I believe you have this in the tools on your iPad as well too, and you'll have access to all the slides. But it is a great resource to go to, and as more therapeutics get added, they'll be added as well. But we really need the ability to reach out to our patients, so team members who can call patients and inform them when we have these therapies available of their eligibility, utilizing the electronic health records to identify patients and push messages out, send video education to them, and then having referral pathways. And I sincerely hope, we actually had in our area even some pharmacies that would administer Evusheld to patients, so I really hope that urgent cares and pharmacies and other places will be able to do these. Certainly oncology centers are robust in their ability to administer these, but we had a whole lot in our institution of immunocompromised patients with underlying rheumatologic conditions or otherwise without access to infusion sites, injection sites, or otherwise, and that's both for prophylaxis but also for therapeutic administration of remdesivir now, monoclonal antibodies previously. Certainly when patients are in the hospital, strategies to get patients vaccinated as long as it's medically appropriate while they're in the hospital if they haven't been vaccinated is a great opportunity as they're a captive audience and on the way out, again, as long as it's medically appropriate to do so, are some of our ways of trying to enhance the immunity for patients. So on your iPad or virtually there is a question, so please take a second to answer that.
So while people are answering, I just want to ask you a question that you and I were just discussing, and it's a bit off topic here, but do you know if current batches of IVIG have useful titers against COVID?
Yeah, that's a great question. So in collaboration with our immunology team, given the high prevalence of vaccinations and infections around the world, they do believe that the current supply of IVIG and gamma globulin supplementation does have therapeutic antibodies, or high titers of antibodies, I should say, against variants that have been present. Now, as new variants emerge, it's going to take time for those antibodies to be present, but that is present in that and provides a passive immunity to patients who are hypogammaglobulinemic getting supplements. Great question. All right, so again, this is just a picture of what the website is of the COVID-19 treatment locator, and there's a box up here, for those of you who haven't seen it, where you can type in an address or a zip code, and it will then zoom you down into the area and show you exactly what's available at the pharmacies and locations in the area so you can help prescribe for patients. Okay, so if we go back to our patient.
At the same time, it's always back of your mind that you have to be cautious. You cannot let go of mask, hand sanitizers, social distancing. Still, you have to practice all of these things because what if this what if this medication is not 100% protecting you, which is not. And also the virus is constantly evolving. My hope is that there are new measures and new medications are being researched for the new variant of the COVID-19. At this point, that previous agents are not effective anymore. I definitely would get the next generations of these medications, but I'm sure I will face the same difficulty as before. Healthcare system should prioritize these patients to receive the vaccination and provide essential protection. I think the healthcare providers, they should advocate more to help these people fight this disease and have access to proper care and proper vaccination and medication.
So in conclusion, in 2023, what we have available are vaccines that really can help the limit of progression of disease, but they're not durable. And so we need to continue giving boosters and the schedule that Dr. Shoham has outlined. We currently do not have available monoclonal antibodies to prevent or treat COVID-19, other than perhaps convalescent plasma, but we don't have monoclonal antibodies that are available. We do have antiviral drugs. The caveats of the drug interactions with Paxlovid, but Paxlovid and remdesivir being the preferred antiviral therapies that we have available. We have to improve our vaccine strategies. We have to develop really and ensure the availability of testing and the ability to get these therapies into our patients who are most vulnerable and most at risk. Continue to educate our patients and our healthcare providers and ensure that we have access to these therapies once they are available. I think, so I just would, we'll take questions in just a second, but thank you to all of our partners, in particular the CLL Society, for whom they connected us with our patient case today and our patient advocates. This is their website. There's information outside as well too. There are handouts and action plans for patients to help them prepare ahead of time, checklists for their risk, information on how to quarantine, and what to do once someone tests positive. So with that, we will pause and take some questions. Feel free to type them in the chat, go ahead.
Terrific. Thank you. That was terrific. Thank you, both of you. One of the questions that came up is it the number of vaccine doses or the duration since the last vaccine that makes the difference? And I'm going to maybe start by answering that it's a combination of all those. So the number of vaccines does matter in terms of getting you a baseline immunity, and then if the last time that the patient received the vaccine was before the newest vaccine became available, then they're probably not as protected as they could be. And it's hard to know what the future will bring, but it's likely that we're going to have additional vaccines as the virus continues to mutate, maybe once a year, maybe once every several years. So I think it will make a difference once you've reached the baseline level of vaccination as to how long it's been since the last vaccine. This is a question, how will the type of chemotherapy, immunosuppressive medications, and whether or not the patient had a bone marrow transplant affect the effectiveness of the monoclonal antibody prevention drugs?
Well, I don't think that the type of chemotherapy, bone marrow transplant, or others will affect the effectiveness of the monoclonal antibody prevention. I think it will impact those eligibility criteria, but I don't think it'll impact the effectiveness of them.
Yeah, I would agree with the one caveat that a person that has some protection of their own, and then you layer on top of that the monoclonal antibody. I'm speculating, although this is speculation, that they might be more protected than somebody who doesn't have protection of their own, but that's just speculation.
Well, fair enough. They might have greater protection. I was looking at it in a deleterious way, so.
How to improve access to COVID-19 prevention in urban versus rural setting? Maybe, Gadi, because you're in Pennsylvania, which has quite a bit of a rural setting.
I was peripherally involved in some of the discussions of the Evusheld rollout because of the transplant ID hat that I have, and I know that our health system really tried to make an effort to ensure that it's not just people at our flagship academic center in Pittsburgh itself who had access to it, but also that people in community hospitals and rural areas also had access to Evusheld. So when we were discussing how to roll this out, yes, we had outpatient infusion places on main campus, which is in the city, but we also had outpatient Evusheld infusion centers across the state under UPMC, which I think helped access. But it was, it was hard. This was hard to do. I think it takes a lot of people to agree and to launch the resources needed to do something like this. And I'm curious what your experience was.
No, we did the same thing similarly. It took a very large village to put all of these in place, but I can tell you that while we were able to reach people in community sites at our health system, there were people who were treated in community practices that did not have the same ability to access these things. And that's why, I step back and I look at how well we've done with employing retail pharmacies to deliver vaccines, and I really think that and/or urgent care centers is a strategy that needs to be looked to for these therapies so that more people have access to them. Because I don't know about your center, but our center, had these therapies available for established patients. We didn't establish new patients in our health system. I'm not saying we wouldn't establish a new patient, but somebody who just called to get one of these therapies, if they weren't an established patient, they had no avenue to go to. And so I think we have to think more broadly. I think our networks can help, but I think we have to get even further into the community.
I do recall in the early days of Evusheld, there were some patients reaching out to us directly from other sites in either Pennsylvania or neighboring states saying, oh, my doctor hasn't heard of this, my health center isn't doing it, I heard you guys are. So this was just a handful of times that we created, a patient record for them in Epic, and they came and they got it and they went back home. But this was maybe 3 or 4 times.
So one of the questions is something I don't know anything about, which is Enovid nasal spray, nose spray. Have you heard of this?
Vaguely, I'd have to Google it and see what the mechanism of action is, but I think what they're talking, I think there's studies looking at nasal sprays in order to either treat or prevent COVID-19. I'm aware that this exists, but I don't know any hard data, and I haven't seen it being recommended by any guidelines.
Thanks. Given the information discovered about COVID virus vaccination, has anyone looked at responses to other vaccination in post-treatment settings like flu, pertussis, tetanus, et cetera? And do you want to take that?
Yes, those vaccine responses, and one of the challenges I would say is that overall responses to flu vaccines are actually lower than the overall response rates, perhaps to COVID vaccines, but we still recommend them and we still advocate that people get them because we want to do our very best to protect people. So they have been looked at, but I think it's the same strategies. And so I will say that our immunology team for patients who are receiving gamma globulin supplementation actually does not advocate immunizing those patients, because if they don't have functioning B cells, then they do not recommend immunizing. Do recommend flu shots, do recommend the COVID vaccine, but not perhaps all of the Prevnar vaccines and the others. But
another question is, If it takes 5 to 6 vaccines to mount a robust response, how often should we counsel blood cancer patients to get boosted again, and does their response last shorter?
This is an amazing question. And I don't think it has an easy answer. And I've known some patients who are up to their 9th or so, and these are the individuals who are actually typically with their primary care physician or their oncologist or their transplant doctor are actually checking antibodies and going by antibody levels to inform when to get revaccinated. So as soon as they're seronegative, they get another shot. And if you look at the fine print of the very complicated diagram from the CDC on how to vaccinate, there's language in there that says that once you're considered fully vaccinated, if you meet certain criteria, specifically if you're immunocompromised, future vaccine booster doses can be given, but they don't really give you any more guidance aside from, I think it's something like every 2 months, and you and your doctor can discuss this. I'm not aware of any other vaccine where it's open-ended like that. And you know, I don't know where the future of COVID-19 vaccines is going to be. Is it going to be an annual thing, or is the guidance still going to be this kind of loose-ended, you can play it by ear and discuss with your doctor? These are challenging cases.
And I think that we don't want to leave our T-cell friends out. It's not only antibodies.
Right.
Yep.
This is actually a question that we get asked a lot, and certainly we do have data, even looking at flu vaccinations, for example, in myeloma patients. Where giving a second dose 3 to 4 months in boosts the antibody responses. And so I do have patients, just as the ones you're describing, who also have had antibody titers checked and are dosing on that basis and have seen increases in antibody responses. But again, we don't know what to do. I anticipate there may be more frequent dosing, particularly in those patients with lower responses, but I think time will tell. The good news is that they're safe. The vaccines are safe. So.
Yeah.
So just wrapping up, there's a question about a pediatric syndrome. Did any of you have expertise in pediatrics? It's prevention of hypercoagulable TTP syndromes and visceral syndromes in kids due to cytokine release. I'm going to admit that I only take care of grown-ups.
Same.
Yeah, sorry.
Sorry.
And this is, I think, a couple of questions. One is, what is the current policy for use of masks in U.S. oncohematology wards for personnel and patients, encouraged or compulsory? I'm going to say that it's diverse based on different parts and different cultures in the country. I would say that if I was king of the world, I would strongly encourage it, bordering on mandating it, but I guess I would be in the very strongly encouraging it.
Yes, I would agree. There's quite a bit of diversity here, and it's really center dependent. There is no mandate. Our institution, pre-COVID, always masked on our BMT heme malignancy services from the beginning of virus season until the end of virus season, prior to even the existence of COVID. And so we have continued to do that at this point in time.
Yeah, it's the same for us. Pre-COVID, during quote-unquote flu season, all our organ transplant and heme cancer wards would be compulsory masked, the rest of the year not. Then in COVID, everything was masked all the time, and now our heme cancer and organ transplant wards are compulsory masking.
So with that, thank you for joining us. You can complete and submit your post-test evaluation for credit. Please do that. If anybody has any questions, feel free to come on up and I'll try to field them.
Thank you all
you.
very much.